Hello and welcome to the session on congestive heart failure. We began by understanding what is congestive heart failure and what is the strategy behind choice of key drugs in management of congestive heart failure. We have seen the details of actions of digoxin, the first drug introduced in management of congestive heart failure. And we saw that it addresses the basic problem in these patients, that is reduced force of contraction, by increasing the force of contraction of the myocardium. However, we saw that use of digoxin is declining. Clinicians prefer to keep the dose to the minimum because digoxin has got a very narrow margin of safety and a lot of adverse drug interactions, plus a tendency to accumulate because of long T-half. So stress or focus of pharmacotherapy of congestive heart failure today is on use of vasodilators. Dilators which by dilating the arterioles can reduce the peripheral resistance, that is, reduce the afterload, and by dilating the veins can reduce the venous return, and that is, reduce preload. Let's go on to see why amongst dilators, ACE inhibitors are the drugs of choice in management of congestive heart failure. So which vasodilator in management of CHF, chronic management or even acute LVF? So we have some arteriolar dilators, preferentially dilating only the arterioles and thereby reducing the afterload. The drugs like calcium channel blockers, importantly the dihydropyridine group of calcium channel blockers. But because they are only arteriolar dilators, rapid acting arteriolar dilators, they are inevitably associated with reflex tachycardia. And tachycardia, whether reflex or direct, is deleterious to the patients of congestive heart failure, to patients with a weak heart. Then we have venodilators like GTN, which predominantly dilates only the veins and therefore reduces the preload. However, GTN has got a very short duration of action, and so we rely on it only by IV infusion in management of acute LVF, like acute situations. Then we come to the drugs which dilate both arterioles and veins. By dilating arterioles, they can reduce the afterload. By dilating the veins, they can reduce the venous return, and that is preload. Alpha blockers are very powerful vasodilators of both arterioles and veins, but they have very strong reflex tachycardia associated with them and postural hypotension by interfering with the baroreceptor reflex mechanism. They also produce or lead to impotence, nasal congestion, and so on. Sodium nitroprusside, another very quick and short-acting dilator of both arterioles and veins, is therefore used only by IV infusion, only in a well-equipped ICU, and therefore again useful only in acute situations like acute LVF. So now we have ACE inhibitors, which are orally effective, safer, longer acting, and they have a unique additional beneficial effect of preventing and even reversing remodeling, which is responsible for worsening of the condition, progression of the condition of congestive heart failure. So what is this remodeling? We already saw that remodeling is a protective structural change in response to some chronic damaging influence. However, this protective structural change does not help the tissue or organ to function better. In fact, it adversely affects the function of the tissue or organ, which undergoes this remodeling. What happens in case of cardiac remodeling? The heart undergoes hypertrophy. This overworked, chronically overworked heart undergoes hypertrophy, which is not just muscular hypertrophy but fibrosis, deposition of collagen tissue, which does not help in contraction. There is increase in intercellular matrix as well, and cardiomyocytes start dying faster. What is the culprit? Who are the culprits responsible for this process of remodeling? It has been understood that the major culprits responsible for this adverse structural change or supposed to be protective structural change, which actually adversely affects the function, is chronic exposure to angiotensin II and aldosterone, and also chronic exposure to sympathetic overactivity. How do these agents bring about this remodeling? They do so by directly increasing the expression of proto-oncogenes and increasing the synthesis of growth factors. Indirectly, they contribute by contributing to the chronic damaging workload by increasing the volume overload through aldosterone and preload and afterload by vasoconstrictor effect. And therefore, AC inhibitors are of a great value in management of congestive heart failure. So what are the beneficial effects of AC inhibitors in management of congestive heart failure? They reduce both preload and afterload by dilating veins as well as arterioles. They can slow down the disease progression by preventing and even reversing the angiotensin II and aldosterone mediated remodeling influence. They're well tolerated. They lack the adverse effects of many other vasodilators. The only important adverse drug reaction, which could be problematic in a few patients, is dry cough. And it is not because of angiotensin II itself or AC inhibitors themselves, but by accumulation of bradykinin, as we will shortly see. The important contraindications are pregnancy and bilateral arterial stenosis. Pregnancy is an important to remember contraindication, not just during first trimester, even during second and third trimester. Common examples to remember are enalapril, lisinopril. The first AC inhibitor, captopril, is no longer used because it was associated with a lot of adverse effects. But these newer agents are most of them prodrugs, and therefore the adverse effect of reflex tachycardia is also minimal because of gradual onset of arteriolar dilatation. So all these newer agents, which are most of them prodrugs, all of them have gradual onset of action, are the preferred agents in chronic management of congestive heart failure, where slow onset is not a problem. Let's see what is actually happening. What exactly are these AC inhibitors doing? For which we need to understand the renin-angiotensin-aldosterone mechanism. So renin is a hormone released from juxtaglomerular cells in the kidneys on the renal tubules. And this renin is capable of converting circulating angiotensinogen into angiotensin 1. Angiotensin 1 is not a very powerful chemical. It is further converted into angiotensin 2 by the action of angiotensin converting enzyme. And the same enzyme is also responsible for degradation of bradykinin. Bradykinin, which is a vasoactive autocoid capable of causing vasodilatation, very strong vasodilator and bronchoconstrictor. Angiotensin 2 is causing vasoconstriction. It's a very strong vasoconstrictor which constricts both veins as well as arterioles. By constriction of arterioles, it manages to increase the peripheral resistance, that is, increases the afterload. By constriction of the veins, venous return increases, so contributing to increase in preload. In addition to this vasoconstrictor effect, angiotensin 2 is capable of releasing aldosterone, which can bring about sodium and water retention, increasing in blood volume. An increased blood volume can contribute in turn to increased venous return. So this mechanism is supposed to serve the purpose of raising blood pressure. It is a part of the compensatory mechanism activated in response to low blood pressure. So it can increase the cardiac output and increase peripheral resistance, which can increase the blood pressure. In a patient of CHF, what these actions amount to is increased peripheral resistance, increasing the afterload, and increased venous return, increasing the preload. So these actions of angiotensin 2, vasoconstriction, as well as release of aldosterone are contributing to further increasing the workload of the myocardium. So what will AC inhibitors do? Yes, and another important thing is aldosterone and both angiotensin 2 as well are responsible for remodeling, which is making things worse for this failing heart. So if we give AC inhibitors, what do they do? they will not allow angiotensin converting enzyme to work. That means they will not allow angiotensin 1 to be converted into angiotensin 2. And if angiotensin 2 is not formed, we will not get release of aldosterone as well. And therefore, both these unwanted actions, vasoconstriction, sodium water retention, as well as remodeling, will be prevented. And these agents have been shown to even reverse remodeling which has occurred before we start patients on AC inhibitors. Another offshoot of this effect, inhibiting angiotensin converting enzyme, is interfering with the degradation of bradykinin. This is beneficial as well as adverse clinical implication. Because bradykinin accumulates and it is a very powerful vasodilator, the vasodilator effect of bradykinin will contribute to the beneficial load reduction effect of AC inhibitors. But this accumulated bradykinin is also responsible for the dry cough, which could be problematic in a few patients started on AC inhibitors. What is the solution for this? Can we avoid dry cough but yet get both these beneficial components of effects, that is no vasoconstriction, no sodium water retention, no remodeling, and no dry cough? Yes, the solution is use of ARBs, angiotensin receptor blockers. They are not interfering with the action of ACE, angiotensin converting enzyme, so they are not interfering in manufacture of or release of angiotensin 2. But they are blocking the actions of angiotensin 2. They are not allowing angiotensin to work by interacting with its receptors. So ultimately, the effects of angiotensin 2 which we did not want, that is vasoconstriction, sodium water retention and remodeling, that purpose is achieved even with ARBs. Though they are not interfering with synthesis, they are not allowing it to do the unwanted actions. Plus, because they are not interfering ACE, they are not interfering with the degradation of bradykinin, so this beneficial component will vanish, but so also dry cough will not be there. So ARBs manage to give us all the beneficial effects of AC inhibitors without producing dry cough. So in patients who complain of dry cough as being problematic, could be shifted to ARBs. So AC inhibitors are associated with dry cough, but ARBs are not associated with dry cough. Other beneficial effects of AC inhibitors are retained with ARBs. Thus, AC inhibitors or ARBs in CHF reduce both preload as well as afterload. They slow down the disease progression by preventing and even reversing remodeling. So they are called as disease modifying agents. They are well tolerated with less adverse effects. Only adverse effect to remember is dry cough. They are contraindicated in pregnancy, and that must be remembered. They are also contraindicated in patients with bilateral renal artery stenosis. They should never be combined with spironolactone, which is also capable of blocking the action of aldosterone, just as ARBs block the action of angiotensin 2. Spironolactone blocks the action of aldosterone by blocking its receptors. So combined use of the two, though some reports recently say that the beneficial effects are increased, combined effect of spironolactone with AC inhibitors or ARBs can land the patient into hyperkalemia, which can be equally dangerous to the patient. And commonly used drugs are enalapril, lisinopril, which can be, importantly, you must remember that gradual onset of action of these agents is beneficial in terms of less reflex tachycardia. So if you have understood and liked this session as well, do express your likes. You can share the website with your friends and do keep viewing the rest of the sessions, lectures on CHF and other topics. Thank you.